Good afternoon, everyone. Thank you for joining us today for our monthly webinar. I will begin with a few things to note as our presenter gets ready to join us via video. So as I welcome you, the first thing I'd like to say is participants will be muted upon entry and all videos will be turned off. For technical assistance, we ask that you please use the chat box located on your screens. You will also receive an email in approximately 3 months requesting feedback and impact on this presentation. And immediately after this presentation, you will receive the evaluation form along with handouts for today's webinar. We ask that any questions that you may have be placed into our Q&A box located at the bottom of your screen. We will be having a 10-minute question and answer segment at the end of the webinar. For future trainings and additional webinars, we ask that you visit our website at www.ncdus.org/training for any other opportunities. I'll go ahead and introduce today's speaker. So our speaker today is Ms. Rachel Flatt, a 2010 Olympian, and a doctoral candidate in the clinical psychology program at UNC Chapel Hill under the mentorship of Dr. Cynthia Bulik. Prior to transitioning to UNC, she served as the program's director at the Center for M2 Health and worked on several projects through both Stanford University and Palo Alto University. She graduated from Stanford University in June 2015 with a bachelor's degree in biology and a minor in psychology. She also placed 7th in the 2010 Olympic Winter Games in ladies figure skating and was the 2010 U.S. national champion and the 2008 World Junior Champion. She retired from competitive skating in 2014 and continues to play an active role in the sports community as an athlete representative for the U.S. Olympic and Paralympic Committee's Mental Health Task Force and Racial and Social Justice Council, U.S. Figure Skating's Board of Directors, and as a U.S. Figure Skating's chair of the Athletes Advisory Committee, among other positions. I will now turn things over to Ms. Rachel Flatt.
Thanks, Lachelle. Thanks everyone for joining. It's good to meet you all and see you all virtually. I am super excited to be giving this talk on eating disorders and disordered eating and body image in athletes today, especially during Mental Health Month. So perfect timing. Before we get started, I usually like to begin my talks with a little bit of personal background so that you have just kind of a background and general understanding of my lens and why I care so deeply about these topics. So in what feels kind of like a prior life, I was a figure skater. Like Lachelle mentioned, I was on the 2010 Olympic team for ladies figure skating, and I was also national champion that year. But after 18 years, I retired from competitive skating during my junior year at college. And that was back in 2014. And I just wrapped up my 3rd year in UNC Chapel Hill's clinical psychology PhD program. So I am working my way through. During the time that I was competing though, I think myself and many other elite athletes that I trained alongside were really, I think, dealing with poor body image, disordered eating behaviors, and some, in some cases, full-fledged eating disorders. And at that point in time, I think a lot of that felt very normalized, if not to some extent encouraged, given how many of us really experienced a lot of criticism on our weight and our physique from coaches, officials, judges, fans, you name it. Because of those experiences, I feel really passionately about contributing to the research base and advocating for athletes' safety and mental health and wellness to really ensure that sport participation is a positive experience. And I also really love helping to provide more educational opportunities like this, because the more people who come into contact with athletes and who are well-versed in eating disorders and mental health more broadly, the more likely we are to kind of change the culture around mental health in sports. So thank you for joining today, and let's go ahead and dive in. I've included the course objectives here as a brief reminder, and I hope by the end of this you feel a little bit more comfortable in recognizing signs of poor body image, disordered eating behaviors, and eating disorders in athletes, and identifying sport-specific risk factors. I also hope you'll be able to talk a little bit more about the considerations related to exercise and training for athletes with eating disorders, and maybe feel a little bit more comfortable in creating a supportive and educational environment to both prevent eating disorders and to promote a more positive body image and self-esteem among your athletes that you work with. So here is our agenda for today. I formatted this talk to provide some really foundational and introductory information across a number of topics without going too much into depth into any one of these things. But generally speaking, we'll be talking about diagnostic and screening considerations, risk factors, treatment considerations, and support strategies, all with a sport-specific lens. So this won't cover everything. There's a lot out there, but I hope this gives you a little bit of a taste of some of the research and some of the things that we're thinking about. Alrighty, so in case this is your first time talking about eating disorder diagnoses, or if you just need a little bit of a refresher, these are kind of the core 3 diagnoses that most people are familiar with. So it's anorexia nervosa, bulimia nervosa, and binge eating disorder. So we'll start with anorexia nervosa. The diagnostic criteria really center on restrictive energy intake leading to significantly low weight or failure to gain weight as someone grows. There's also a really intense fear of gaining weight, and there's a distortion of understanding of one's body shape or the seriousness of the illness, or kind of placing almost all of one's self-worth on their weight and body shape. Now, in terms of the restricted energy intake, this usually occurs through one of 2 kind of pathways. The first being caloric restriction, where folks really severely limit their intake, and this is called the restrictive subtype, or through binge and purge cycles, which is the binge purge subtype. And when we're talking about objective binge episodes, this is when people are eating a large amount of food, typically in a short period of time, with a complete loss of control over their eating. So for folks with anorexia and bulimia nervosa, they also engage in compensatory behaviors to purge themselves of the food or the calories. And usually folks do this through either vomiting, diet pill, laxatives, diuretics, or fasting, or through excessive exercise. Now for bulimia nervosa, like I just mentioned, these folks tend to engage in binge and purge episodes at least once per week over the span of 3 months. And they often, again, place a lot of their self-worth on their weight or their body shape. And finally, binge eating disorder is essentially where folks are engaging in objective binge episodes, and there's a lot of distress and impairment surrounding the binges. Now, DSM-5 also has unspecified feeding and eating disorders, and we also have other specified feeding and eating disorders, which I'll just briefly mention. The other specified feeding and eating disorders also include purging disorder, night eating syndrome, binge eating disorder, bulimia nervosa, where there's less frequent behaviors or a shorter duration. And there's also atypical anorexia, which is essentially when folks meet all the criteria except for the low weight or significant weight loss thresholds. Something to briefly note that is common, I think, for athlete populations is that for atypical anorexia nervosa, this might be a little bit more common than we might see in general populations, in that due to the musculature that some athletes have, or having to meet some of the weight classes like wrestling, for instance, they may not have that typically low weight benchmark that you might see in other anorexia nervosa cases. So just as something to remember, their presentation might appear akin a little bit more to anorexia without the significantly low weight, thus kind of meeting criteria for atypical AN. So now let's talk about some considerations specific to disordered eating behaviors in athletes. When you're screening for these things, there's a few things to kind of keep in mind. The first is the possible seasonality of these behaviors. So when you have athletes who have distinct competitive seasons and off seasons, sometimes there's an ebb and a flow to these behaviors. So for instance, with the Olympics and the Paralympics coming up, which I hope you're all pretty excited about, I know I am, you might see athletes who are engaging in a lot more restriction or more frequent excessive exercise episodes to cut as much weight as possible, kind of in the hopes of reducing their weight and improving their performance, kind of leading up to trials or leading up to these big events. But after their season's over, you might see fewer purging behaviors, you might see more binge eating, you might see a less intense focus or scrutiny on their weight and shape, or athletes might stop engaging in these behaviors altogether, just to give their bodies a little bit of a rest. So it's important to be screening for these behaviors routinely throughout a season, just to see if there are patterns and to make sure that you're not missing these behaviors that might be occurring during the competitive season, but might not be occurring during the off season, especially if that's the time when you're screening. In terms of objective binge episodes, I think most folks would probably consider eating a few burgers, 2 baskets of fries, and maybe a pint of ice cream in one sitting might be enough in terms of the quantity to qualify for an objective binge episode. However, the caloric demands on athletes who are training, 7, 8+ hours a day are much larger than the average person who is physically active for, maybe half hour to 60 minutes per day. So, you could think about Michael Phelps or, football linebackers who might be consuming upwards of 10 to 12,000 calories a day just to keep up with training demands. So what I just described as possibly an objective binge episode solely in terms of quantity might actually be a typical meal for some of these athletes just in order to retain their weight and their muscle. So when you're thinking about the quantity of an objective binge episode in athletes, it's really important to consider their total calorie consumption during a training day, plus the amount of time that they're training and the intensity of that training, just to gauge for whether it's more of a subjective or objective binge episode. But again, the line here is a little bit blurry, so it's really important to rely on your clinical judgment and see what other symptoms are kind of circling around that. Another thing to consider is that a lot of athletes at an elite level are drug tested routinely. I even had drug testers come to my high school in one instance because that was my designated timing frame. So it happens a lot. So if those athletes are using unapproved or unreported laxatives or diuretics or diet pills, or really any other unapproved substance or unreported substances or supplements, this could result in a positive drug test. So it's feasible that these athletes might not engage in these types of purging behaviors as frequently as we might expect compared to a general population. And this would be particularly during the competitive season if they're getting drug tested routinely. But if you find out that an athlete is using any of these substances, especially as part of an eating disorder kind of presentation, it's really important to ask them if they are getting drug tested for their sport and to think through some potential consequences. All right, so now let's talk a little bit about exercise more specifically, since as we all know, this is what athletes spend a lot of their time doing. There are a ton of different descriptions of some form of maladaptive or problematic exercise. So these descriptions include excessive or compulsive or obligatory exercise, or it could also be described as exercise dependence or addiction. And there are slightly different nuances to each of these descriptions, but generally speaking, the way we conceptualize these exercise behaviors is that there's a sense of feeling driven to exercise, which generally helps alleviate some form of distress. So most athletes use exercise to modulate their affect. So for instance, if they're feeling really negatively about their weight or their performance, they might use excessive exercise to help mitigate some of those negative feelings of guilt or shame, or maybe even frustration. They might also use exercise as a way to control their weight and shape, or to purge themselves of calories, much like other compensatory behaviors. Now, back in the 80s, it was originally proposed that there was primary and secondary exercise dependence. So essentially what this means is that there were primary and secondary features to an eating disorder. So for primary exercise dependence, this generally meant that these folks were presenting without eating disorder pathology. And for secondary exercise dependence, the primary concern is eating disorder pathology, but these folks also engage in some form of maladaptive exercise. So when we have athletes who are screening positive for anorexia nervosa with a binge purge subtype, or for bulimia nervosa, and they're engaging in excessive exercise, These would typically be athletes with secondary exercise dependence based on this kind of conceptualization. Although there are a lot of different ways to describe kind of these maladaptive exercise behaviors, there are slight differences in the conceptualization, like I said, but the most important takeaway is that the exercise is problematic. It's helping the athlete kind of mitigate some negative affect, and it's helping to control their weight and shape or purge themselves of calories. So a good example of this might be an athlete who is using exercise to kind of regulate their mood after, a bad training session, and they go and use the elliptical for 2 hours when they feel really disgusted or ashamed of themselves. Another example might be an athlete who feels like they just cannot afford to miss a day of practice, to the point where they consistently train through fatigue, illness, and injury, and to the point where they're really missing other important aspects of their life. So if you are concerned about an athlete's exercise, or if you're looking to use a measure in your research, here are a few measures that you can check out. The athlete's relationship to training scale, or the ART, was specifically designed for athletes. And the other measures that I have listed here have all been used in other athlete populations, even if they weren't necessarily designed for them. But using measures like these can be really helpful to understand what the athlete's relationship with exercise is, and if and how they use exercise to kind of modulate their mood, and if their training regimen also as well is becoming negatively impacted by the additional exercise, for instance, that they're using outside of their regular training. So for instance, if a patient is coming in to an inpatient or hospital setting and they're medically unstable because of extremely low weight and malnutrition, it's really important to know whether that athlete actually has some form of problematic exercise behaviors, or if it's really not an issue for them. There's actually some initial research, and this is very low level or very preliminary research, I should say, in showing that very small amounts in a really controlled environment with a lot of supervision, physical activity can actually be helpful, especially as an athlete is rebuilding their relationship to exercise. Now, again, this requires a lot of psychoeducation and retraining. And if you think about it, this might be the best place for them to kind of start their relearning process, simply because of the amount and high level of supervision, instead of cutting off all access to any form of physical activity until they're completely done with inpatient and outpatient treatment. We don't want to cut them off entirely and then send them back out into the world, not having provided some education and support for relearning how to exercise and train appropriately. So I'm certainly not saying that athletes who are medically compromised should be allowed to train regularly. Obviously, through different levels of care and eating disorder presentations, constraints on exercise are going to vary a lot. And when an athlete is depending on their sports career for scholarships or funding or sponsorships, there might be a little room for some flexibility to not pull sport from their life entirely, especially if it's something that really aligns with their values and identity. So those are just some things to kind of keep in mind as you're screening for these things. So if you don't happen to have some of these measures offhand, here are a few things to look for, both in terms of the quantitative aspect and the qualitative aspect. So you definitely want to look at the total number of hours that they are exercising, and if and how time is spent outside of training, doing some additional exercise. And you also kind of want to look for whether it's cardiovascular training or if it's weightlifting. For instance, if you have athletes who are engaging in a lot of cardiovascular training, it might be in service of helping them to lose weight. Whereas if they might be weightlifting, it might be used to help kind of tone their bodies or increase muscularity. So for instance, in male athletes, you might see a little bit more weightlifting as a form of compensatory exercise. And then you definitely want to look at the qualitative aspects of exercise. So here you might be looking for feelings of guilt or anxiety if they're unable to exercise. You definitely want to look for whether they have kind of obsessive or intrusive thoughts. For instance, if you're familiar with how patients with an eating disorder really almost focus obsessively on food or weight or shape, you might also see some folks who have that same level of focus and scrutiny with their exercise. And generally, there are a couple types that we see clinically. So folks who either vigorously exercise, so think about athletes who might be spending hours on an elliptical, really exercising hard. Folks who had kind of a marked increase in daily movement as part of the eating disorder. So they went from, kind of exercising a normal amount to really kicking up their level and intensity of exercise. Or you might have folks who have what's called kind of motor restlessness, where they just can't sit still. They're constantly fidgeting or bouncing their knees. And it's really not a part of another illness, for instance, like ADHD or to help with some anxiety. Now, sometimes, and I think this is a bit rarer, you will see athletes who don't actually present with engagement in the exercise itself, but they have the same obsession with physical activity. So you might see this in an athlete who, for instance, is injured and can't exercise, but is still actively restricting their intake and just cannot stop thinking about exercise, not just because they miss the sport, but because it's really tied to their weight and shape concerns or the distress that they're experiencing. And then, of course, you might see athletes who are training and competing through illness and injury. And this goes above and beyond, I think, what most athletes have experienced at some point in their lifetime. This is consistently training through, you might see athletes who are reporting a high number of stress fractures, for instance, and still training through that and exercising in spite of those injuries. And then finally, you definitely want to look at the impact on quality of life. So elite athletes have to make a lot of sacrifices. And I, I certainly think about my career where, I didn't have the most interesting social life as a high school student, especially when I was in a full academic load. And I was training 7+ hours a day. And that was the year that I went to the Olympics. I still went to school dances on occasion and hung out with friends. But if you have an athlete whose social life or their daily function overall is really suffering because of their relationship with exercise and above and beyond training, that's definitely a red flag. So as one final example before we move on, kind of the nature of eating disorders is that folks often become really secretive. So it's not uncommon for providers or family members to not recognize these behaviors right off the bat. And they can kind of disguise themselves as kind of being overachievers in the sport by going above and beyond their usual training. So it's probably not so worrisome if an athlete, for instance, is cross training with another sport and they are getting supervision from a strength and conditioning coach. But if they're hiding additional exercise outside of their regular training times and they're reporting discomfort with rest or periods of inactivity, that might be another indicator of problematic relationship with exercise. So I want to briefly touch on two aspects kind of adjacent to eating disorders that are not recognized as eating disorders within the DSM-5, but are often talked about in the context of sport. The first being orthorexia. So essentially what orthorexia boils down to is kind of an obsession with healthy eating. So signs and symptoms kind of include only having a small group of foods that are allowed, and those are typically called safe foods, spending large amounts of time thinking about food and meals, maybe some compulsive checking of nutrition labels and ingredient lists, distress when safe foods aren't available, weight and shape concerns may or may not be present. They might be cutting out an increasing number of food groups altogether. So for instance, all sugar, all carbs, all dairy, all meat, all animal products, and it's really not due to a specific medical concern. And sometimes folks describe this as an inability to eat anything but a narrow group of foods that are kind of deemed healthy or pure. So this is especially prevalent in athletes because there is this combination of kind of diet culture in our society generally, and the added magnification on fueling your body appropriately with the best possible food to get the best performance. There was a recent study that was conducted, I think by Clifford and Blythe, in that they found in a sample of student athletes in the UK, it was actually just over 3/4 of the sample reported symptoms of orthorexia. And the actual prevalence was around 30%, but still, I think it's really goes to show how common this is in athletes and in the sport culture more broadly. All right, so the final thing I'll mention before we move on is the relative energy deficiency in sport, which most people either referred to as RED-S or REDS. This originally stemmed from the female athlete triad, which was conceptualized as disordered eating, kind of leading to menstrual dysfunction, poor bone health, and low energy availability. And this model was kind of expanded so that it didn't simply focus on women and was more inclusive because clinicians were really seeing these same issues across athletes from all walks of life. So the underlying problem with RED-S is an inadequacy of energy to support the range of body functions involved in optimal health and performance. So usually this means that athletes are burning too many calories or not taking in enough to support their daily functions and training, or it could be a combination of both. So I put up the spoken wheel model from Mountjoy and colleagues' International Olympic Committee consensus statement. And because of the low energy availability, you might see a variety of health consequences associated with RED-S for athletes. So these include negative effects not only just on menstrual function and bone health, as in the female athlete triad originally when it was proposed, but you might also see an endocrine, metabolic, hematological, cardiovascular, gastrointestinal, and immunological systems. You might also see negative effects on psychological health and growth and development. And later on, I've listed some specific consequences that we'll talk a little bit more about. But again, this is not an eating disorder specifically. This is just kind of a constellation of symptoms that you might see and some consequences. But I would highly recommend checking out the 2014 IOC consensus statement and the 2018 update on this because it's great body of literature. All right, so now that we've talked about some athlete-specific considerations for diagnoses and disordered eating behaviors, I've listed a few brief screening tools that were designed and validated in athletes. And generally, these aren't full-blown diagnostic tools. So you won't get an output of, oh, this athlete has met criteria specifically for anorexia binge purge subtype. But you'll get an idea as to whether these athletes are endorsing features of an eating disorder or disordered eating behaviors, or if they're at risk. And one thing that I'll point out too is that the brief eating disorder screen for athletes, or the BETA, was actually included as part of the IOC's Sport Mental Health Recognition Tool, or the SMAT. So if you are using one of these screening tools and you aren't trained in eating disorder treatment or assessment, it's really best to refer out and get a full diagnostic screen completed if you see any form of risk or any behaviors or any psychopathology kind of popping up. So let's spend a second talking about prevalence. Now, most research out there suggests that athletes actually demonstrate a higher prevalence of eating disorders compared to non-athletes. So Bratland-Sanda and Sungat-Borgen's 2013 paper illustrated that the prevalence of eating disorders was up to 9% in male athletes and up to 33% in female athletes, with up to nearly 45% endorsing some disordered eating behaviors. Now, take a second to compare that to the 1 to 5% in the general population in larger epidemiological studies. So I think some of you might be wondering, why is there such a large range? And certainly depends on a lot of things, including the research design and the measures and all sorts of good stuff. But competing at a reasonably high level in leanness sports may be one of the larger contributing factors to the much higher prevalence that we're seeing. And these are sports that athletes kind of perceive to have a competitive advantage if you are thinner and leaner. So these are sports that focus on aesthetics like figure skating and gymnastics, weight class sports like wrestling or lightweight rowing, or endurance sports like long distance running and cycling, or flight sports like ski jumping. And that's just to name a few. That's certainly not an exhaustive list. We'll also talk a little bit more about sport-specific risk factors that may be contributing to the elevated prevalence in just a sec. But there are some initial kind of research studies that suggest the high prevalence may actually extend into the first 5 years of retirement. And so you might see athletes whose risk actually decreases. For instance, if you have athletes who are in a really negative coaching environment, whose coaches' negative comments are kind of maintaining the eating disorder, and when they transition out of the sport, they're no longer kind of exposed to that same environment. And so for those folks, that might be actually beneficial and might actually reduce their risk and may help them recover from their eating disorder. On the flip side, you might have athletes who are retiring, and given that they're no longer training 7 to 8 hours a day, and they continue eating in the same way, they might put on weight or their shape might change. And those might kind of trigger some intense weight and shape concerns, and that may devolve into some disordered eating behaviors. So, there may be a little bit of crossover for some folks, but again, there's a lot more research that needs to be done for athletes in terms of their retirement. And I think the kicker here is that keep in mind that athletes often underreport their symptoms or don't realize that what they're experiencing is a legitimate issue. So again, that might be contributing to some of the range in prevalence, but we also know that athletes are really good at hiding injuries as well as mental health concerns. So it's really important to kind of keep that as a caveat in your mind when you're assessing and when you're thinking about prevalence. One note, we have extremely limited data or pretty much no data on athletes who also have marginalized identities, including BIPOC athletes, trans athletes, or athletes with any other marginalized identity. But I think we can imagine that given the combination of these identities, plus the added kind of sport specific risk factors, we might see some increased risk here as well. So why might athletes be at greater risk of developing an eating disorder? Now, these are some general aspects about a person and their environment that might increase their risk of developing an eating disorder. So I have these kind of grouped into genetic and biological risk factors, psychological risk factors, and environmental and behavioral risk factors. Now, these are pretty well documented in the literature at this point. So you might see some risk factors related to gender. For instance, females are much more likely to develop an eating disorder than men. Or you might see age or certain personality traits like perfectionism, poor body image. Lots of social comparison is definitely something that we see a lot of the time for general risk factors. And then you might also see some peer and family and coach and teammate pressures. You might also see some social media exposure that might be contributing to eating disorder risk. There's lots of things here that might be contributing. But when we think about sport-specific risk factors, there's a slightly different kind of or added factor to this when we think about why some of these athletes might be a greater risk of developing an eating disorder. So like I mentioned already, we certainly have participation in sports that emphasize leanness. And we also see athletes tend to be at greater risk of developing an eating disorder if they're specializing in sports early on or in one sport in particular. Now, we also will see personality traits commonly found in elite athletes and those with eating disorders. So if you think about athletes who tend to be really compliant with their training, or they're very perfectionistic, or they have very high expectations of themselves, or really good attention to detail. Like my advisor likes to say, a really good athlete also tends to be someone who also makes a really good eating disorder patient, because they are so focused on their body image, they're really perfectionistic, they have great attention to detail. So we tend to see a lot of overlap in personality characteristics with elite athletes and folks who eventually go on to develop eating disorders. Now, interestingly, another factor that has contributed to some risk in terms of eating disorders is traumatic injuries. Now, there's not a whole lot of data there yet, but that's something to be mindful of. Now, a biggie, of course, is when athletes are required to wear revealing attire or uniforms or sports gear. And I think this, intuitively makes a lot of sense given the focus on athlete bodies when you have to wear, a small revealing leotard or swimsuit. Now, anecdotally, a lot of athletic departments talk about how the folks who actually order uniforms are often some of the first to notice a significant weight loss in an athlete prior to a season, because that they see the orders for uniforms have actually drastically changed, for instance, from a large to an extra small in a short period of time. So it's just kind of something to be mindful of. And then there is athlete identity. So this is really how much an athlete resonate, or how much a person really resonates with being an athlete, and how important that is to their value system. So if you think about athletes who, for instance, were in the weight of gold, they often talk about how important sports was to them, and that it was really the most important thing in their life. And so when they transition out of sports, or if they're having some difficulty with their sport, that may make them more prone to developing any sort of mental health concern, but really specifically an eating disorder in this case. And then there are certainly negative coaching comments and behaviors. I think so many athletes can name comments that have stuck with them over the years. And as a provider, I think we really don't want to contribute to that as well. So avoiding kind of those cursory or judgmental comments about weight and shape and diet are extremely important, especially because athletes look up to people like coaches, parents, and healthcare providers as role models. And as people, we're just trying to help them become better athletes. So they often hold our comments in really high regard. So that's just something to be really mindful of as you're talking about weight and shape, or as you're talking about their eating and dietary patterns. Next, there is pervasive body shaming and diet culture messages. And I think we're all probably familiar with this, both in terms of our larger society, but I think this is really magnified, especially for elite athletes, and their kind of dealings with the media and commentators making negative comments about their weight and shape. So those are some things that I think really, unfortunately, contribute to risk factors that are somewhat unique to sport. And again, tied right with that is kind of the sexualization and objectification of athlete bodies. Now, these are certainly not the entire group of risk factors. There's a lot that may serve to increase risk and maintain eating disorders that are unique to sports, but these are some of the big ones that have been well researched at this point. So as you can see from many of the risk factors, a lot of them have to do with kind of an intense focus and scrutiny on an athlete's body. So let's briefly talk about body image. Body image is the collection of thoughts, feelings, and behaviors related to how individuals view their body. So poor body image, of course, kind of refers to this negative and unrealistic viewpoint, which often manifests as negative and disparaging thoughts and feelings about themselves. So part of eating disorders is certainly poor body image. And I think we talk about this a ton in sports, but we don't really do so in a productive way, especially because athlete bodies are so often idealized in our society more generally. And I think, unfortunately, if you ask most athletes, it's probably safe to say they've struggled with poor body image at one point or another, whether due to their own concerns or because someone else made negative comments about their body. So what does poor body image look like in athletes? Well, it looks pretty similar to what we would typically expect to see in folks who have eating disorders or disordered eating behaviors generally. So we often see a lot of body checking or self-scrutiny over their appearance. So you might see folks kind of pinching and pulling at their waistline, or just kind of generally at their body to see if and how their body might look if they were to lose weight or possibly put on more muscle. They might be avoiding mirrors or photographs altogether, or spending large amounts of time in front of the mirrors to kind of scrutinize their body. There's a lot of self-criticism about shape, weight, and appearance. So I think a lot of folks are probably familiar with locker room talk, where athletes will say, oh gosh, I'm feeling so fat today, or I'm feeling so bloated today. And those types of comments can, just be thrown out in a cursory fashion, but they could actually be kind of representative of more underlying kind of poor body image and possibly more psychopathology there. They also might have a belief that something is wrong with their appearance. So they might be commenting, for instance, when they're watching videos of themselves in terms of their technique. And they might say, oh gosh, this video is just making my bum look huge right now. And there's no way that my body looks like that. So there might be some comments that are made in that kind of a capacity. There's also a lot of comparison to others, whether that's fellow athletes, celebrities, friends, social media, et cetera. I think this is extremely common in sports. And it might not just be about thinness. It might be about their muscularity. It might be about how someone's physique might be able to allow them to do certain skills that athlete can't do. But it's also hard to not compare when a ton of websites, if, even you can look at this on Google, a lot of websites list an athlete's weight. So I've actually seen athletes go and look up another famous athlete's weight and use that as a goal to get down to in order to be successful. And then finally, you've got folks who are feeling self-conscious or down about their appearance. So an example that I used to see all the time in skating is that athletes would feel self-conscious about their costumes or even in their training clothes. So even when they're, really getting hot and sweaty during their training, they would stay completely bundled up so as to not show their body or their physique. So let's talk a little bit about treatment considerations. Now, I think most of us are probably fairly familiar with general barriers to treatment, like high cost, the perception that mental health problems don't need treatment, minimal access, low availability of providers. There's a number of pretty substantial barriers to treatment. But in terms of barriers to treatment for athletes, we actually know that athletes tend to seek mental health treatment at a lower rate than the general population. So why don't they get in the door? Well, there's a multitude of reasons. It could be due to lack of time and rigorous training schedules. I mean, when I was competing as an elite athlete, I was usually waking up around 5:30 in the morning, going right to the rink, and then spending a full day at school from like 8 a.m. until 2 or 3 p.m., immediately going back to the rink and training from like 2:30, 3 o'clock until 5, 6, 7, sometimes 8 or 9 o'clock in the evenings. And then I'd have to go home and go do homework and immediately go to bed. So there was very little time for me to spend time with a mental health care provider, and it felt pretty low on my list sometimes. There's also frequent travel for events. For instance, I missed 2.5 months of school during my Olympic season, just to give you an idea of how often some of these athletes might be traveling. So that certainly makes it really difficult to set up routine appointments with any mental health care provider. There's also a much higher stigma surrounding mental health in athletes compared to non-athletes. So I think that's something that is working to be addressed in a lot of spaces right now. But we just have to continue to talk about eating disorders and mental health more broadly, so as to help and facilitate some of these athletes to go seek treatment. Sometimes athletes have negative interactions with healthcare providers or fearing that they might be perceived as weak if they seek treatment. In addition to this, there are very few providers out there with a combined eating disorder and sports specialties, and there are very few treatment centers that focus specifically on athletes. So if an athlete, for instance, is hospitalized with an eating disorder, that usually means any and all physical activity and their relationship with their sport is totally gone for an extended period of time. So if you are an athlete who depends on their sport for a variety of things, that doesn't sound too good. So I think there could be some really negative career consequences as a result of seeking treatment. For instance, folks could lose their sports scholarship, or they could lose funding if they were to seek treatment, just because of the stigma, just because of the time constraints. So there are a lot of things that we can be doing to help alleviate and reduce some of those barriers. I think we have to make time in their schedules. We have to promote the importance of seeking treatment. We have to keep the conversations going about mental health to help decrease the stigma and change the message around perceived weakness. And we can increase training and education of providers and athlete-facing staff, trainers, coaches, etc. I think we just have to continue getting the message out that we're really prioritizing their health and wellness as a human and not just an athlete. So once you get athletes in the door, how do we increase their buy-in so they aren't so treatment resistant? With the mental health model in sports, we know that better mental health leads to better performance. So we can kind of package this as a performance issue. And I think a lot of athletes are entirely focused on getting back to their sport. So sometimes the message that we really care for their health as a human being and that we care about their long-term wellness doesn't quite resonate. So presenting treatment and reaching treatment benchmarks as a way to get back to sport and most importantly, to have a better experience in sport might be a way to get them more engaged. So as a part of getting buy-in, you can certainly talk about the short-term impacts of eating disorders. And these include electrolyte imbalance, breakdown of muscle, slow heart rate, low metabolic rate and blood pressure, stomach pain and bloating, constipation, difficulties concentrating, muscle cramps, fading, and dizziness. Again, this is not an exhaustive list, but these really target the immediate negative impacts on performance in training and in competition. So, if I were to think about, and I don't know about you, but if I were to think about training and if I was dealing with stomach pain and bloating or dizziness when I was spinning all the time, usually didn't end well. Then you can also focus on the long-term consequences. So again, you can read through this list on the left side. Of note, I think it's really important as a provider to be able to mention the fact that, especially for athletes who are presenting with kind of long-term or severe and enduring anorexia, it actually has the second highest mortality rate of any psychiatric illness, and it's only second to the opioid addiction crisis. So again, if athletes really want to have these long, or they really want to have a longevity in their career, and if they want to be kind of the the next Simone Biles, and they also want to be an engineer in their lifetime, engaging in treatment and recovering is going to be the best way forward. Again, this is another spoken wheel model from Mountjoy and colleagues on the IOC Red S statement, but again, it's talking about the potential performance consequences of Red S. So lots of similar things to what I just said. And two things that I'll kind of point out here is that it can actually result in impaired judgment. So if you, for instance, are a tennis player and you're trying to decide on your serve strategy to win your match point, like your judgment may not be totally on point. It's also associated with other psychiatric comorbidities like anxiety and depression. So if you have some of these concerns, the athlete isn't just wrangling with one diagnosis. And clinically, I think it's pretty rare that we actually see an athlete only with an isolated instance of just an eating disorder or disordered eating behaviors. Usually we see kind of a constellation of psychiatric illnesses. So again, we're really not trying to scare the athlete, but it's really important to emphasize intervening early and ensuring the athletes get the help they need from professionals, and being able to list some of these potential consequences as maybe these are some reasons why you might want to engage in treatment so that you have a long-term and successful and healthy sports career, and you can go on to do other incredible things in your life. When you have the opportunity, I really recommend trying to work directly with the sports medicine team that is comprised of a lot of folks. Having everyone on board with a treatment plan actually reduces the chances that an athlete is kind of going to slip through the cracks or gets mixed messages that might be confusing from different people on their support team. Kind of same thing here with coaches and trainers who aren't necessarily part of the core treatment team. So keeping coaches and trainers informed as needed with the athlete's consent is really important. And I can't stress that last part enough, because I think for folks, especially for folks who work in some of these integrated athletics departments or athletic settings, it's really easy to inadvertently share some information about an athlete. And then, the coach might go share that information to the athlete directly. And the athlete's like, what? I didn't share that information, or I shared that confidentially. And I didn't want my coach to know or my teammate to know that I was in eating disorder treatment. So again, making sure that you get that consent from the athlete first is really important to make sure they're on board with having the remainder of their team kind of have a good understanding of what's going on, so that there's really kind of this catch-all concept. And then another option here is to create a specific exercise plan and an eating disorder return to play plan. So kind of considering all the things that I've mentioned before about exercise, I think it's really important to come up with a training plan, and when it's safe to kind of incrementally increase training and to get the athlete on board with meeting certain treatment benchmarks. So for a lot of folks who are on sports medicine teams, you're probably pretty familiar with return to play plans for injuries, which essentially outline treatment steps and benchmarks in order for an athlete to return to full training and competition mode. You can do the exact same thing here with eating disorder treatment. I think it's really important, particularly for outpatient care as well, that you put these together, because you really don't want an athlete going from, a really high level of care at an inpatient level to a stepping down all the way to outpatient treatment without having any kind of plan in place for after they finish their treatment. And I think when you consider that transition out of treatment back into full sport, it's really important to think about whether or not having these kinds of discussions with a multidisciplinary team or with their teammates could potentially be triggering, especially for some of their other teammates who might be dealing with some of these issues as well. So a couple things to consider there. Now, quickly before we wrap up, let's talk about support strategies. So if you are hesitant to talk about eating disorders and mental health, let me tell you, you are not the only one. These are super tough topics to navigate, and it is especially hard when there is so much discussion in sports about an athlete's eating habits and their body, which is just inherently a part of the sports culture. If you are concerned about an athlete possibly having an eating disorder or engaging in some disordered eating behaviors, I've included some good starting questions here from Joy Kasman and Natib here on the left-hand side. And if there's one thing that you kind of take away from this presentation, I hope it's what I have on this slide here, kind of regardless of your career or your interactions with athletes. I think it's pretty evident with all I've described today that eating disorders are extremely complex, and that's probably an understatement. So when you're talking to anyone, let alone athletes, about your concerns, really try to avoid some simplistic comments. Like if you're talking about an athlete who identifies as a man, or non-binary, please don't say, well, eating disorders are kind of a female disorder. Well, it's true that eating disorders are more common in women. Eating disorders absolutely impact people from all walks of life. It's also really important to express your concern and to be clear about the observations you've made. So do so in a really neutral and caring way by using I statements. So an example of this is, finding a private place to say, hey, I'm really concerned about some comments I overheard you say about your body image in the last practice. My top priority is your health and safety. So I'm wondering if we can talk about it. And I'm wondering if you would be willing to schedule an appointment with your primary care provider or with a mental health care professional. Again, give clear guidance on how to schedule these evaluations with an experienced provider who has eating disorder expertise, and make sure that when you approach that conversation, you have that list ready to go. And please be sure to follow up with the athlete or their parents, kind of depending on who you're having that conversation with. And finally, I think we can all be a part of creating a healthy training environment. So you can do so by encouraging intuitive eating, mindful movement, and body positivity. If you are eating for some reason, eating with athletes, like if you're a team physician and you're on an international event with them and you're all sitting in the dining hall together, try to eat healthfully in front of them and don't make comments about what the athlete is eating. I can't tell you how many times I've had this happen where I've had coaches or officials come up to me in dining halls say, you shouldn't be eating those carbs, or you shouldn't be eating that one spoonful of frozen yogurt that you just got, even though it's like 90 degrees and sunny today. I think it's also really important to emphasize strength and ability and overall health and wellness rather than thinness. Again, this is a really common message, especially in some of those leanness sports, to focus on thinness or being as lean as possible. And so being able to speak to their abilities as an athlete and also who they are as a person more generally is really important. Again, avoid fat talk. So avoid kind of talking about your own body image concerns, or avoid making kind of cursory comments about your own weight and shape, or engaging in fat talk about other athletes. Because if you are discussing athletes' weight or shape with your athlete, it really encourages social comparison, and it really makes your athlete kind of wonder what other kinds of things you might be saying about them. So on the whole, there's a number of things that you can kind of engage in just off the bat, even if you aren't an eating disorder professional. These are just some general things that you can do to help improve the overall sports environment. So lastly, here are some highlights. I hope at the end of this hour, you feel as though you have a slightly better understanding of some of the considerations around eating disorders, disordered eating behaviors, and body image, and their associated risk factors in athletes. and especially in terms of how they may present clinically. I also hope you feel like you have a slightly better understanding of some of the treatment considerations and basic support strategies. And I know we spent a lot of time talking about exercise, so I really encourage you to start weaving in some questions about both the quality and the quantity of exercise athletes are engaging in. So here are my references. That's all I have for today. I sincerely hope you were able to take something new away from this presentation. And with this being Mental Health Month, I'm very appreciative that you all spent a little bit of time with me on a Friday. So thank you very much. And with that, I will turn it over for questions in the last 5 minutes.
Thank you so much, Rachel. Great presentation. As a reminder, I just want you to know that you will be receiving an email as a participant after this with the evaluation and handouts of today's presentation. I'll now address questions that have been asked by the participants. So Rachel, our first question is, are there any good references of ED/DE after coach comments? Would also like to know about the orthorexia study reference if possible.
Absolutely. So I can definitely send out the orthorexia sites or citations after this presentation. So I'll make a note of that to include that. But in terms of some, I may have misunderstood this, but in terms of the kind of the comments that coaches might make in terms of either disordered eating behaviors or eating disorders, I think sometimes coaches will say, I mean, there's many examples that I can pull from offhand, but there were some coaches in the past who I remember talking about athletes who were losing weight and were talking about how they would never be thin enough unless they looked like they had just walked out of concentration camps, which was horribly insensitive and horrible to hear. But these are the types of conversations that are somewhat normalized in the sports community. So, I guess that really speaks to the fact that people were, focusing on restricting intake as much as possible and focusing on, as much compensatory behaviors to reach those goal weights. And again, certainly not all coaches are like that or have those perspectives. But again, I think in sports, at least for the last several years, there's starting to be some changes around how coaches in particular are kind of approaching their athletes and what they understand is okay to say and what is not okay. So again, that was on the very extreme end. But yeah, there's definitely a lot of things that coaches I can immediately think of that were said to me over the years and other athletes that could be contributing to the eating disorder or disordered eating behaviors.
Thank you for that, Rachel. The next question says, I study neuroscience relating to eating disorders. Do you think that there's benefit in educating athletes about the underlying biology of eating disorders? And this is also from a former figure skater.
Go former figure skaters. Yes, absolutely. I think one of the most common things I say when I'm doing interviews about mental health is that it is essential to provide the psychoeducation to any eating disorder patient that there are biological underpinnings to the disorder itself. And I think that really helps to alleviate some of the blame and shame and guilt and problems around self-worth when there are conversations about mental health. So I completely support that. That is something that I know I didn't cover in this presentation because we don't have really any athlete-specific neuroscience research in relation to eating disorders. So that's definitely a space that I think is a great opportunity to talk about just in terms of the general science. And I am hugely supportive of having those types of conversations with the athletes that you work with.
Thank you. I'll go ahead and do one last question with the limited time we have. The remaining unanswered questions will be sent in an email with responses from Ms. Flatt within a week. The next question is, in your experience, are there any cons to the coach or athlete acknowledging that the eating disorder is happening, or is it always a good thing?
So I think in most cases, it is a good thing. However, I think you have to do a lot of assessment up front to make sure that the coach isn't a contributing factor to the maintenance of the eating disorder. So for instance, when you have coaches who are making a lot of negative comments about an athlete's weight or shape, that might not be an instance where you immediately want to go tell the coach, right? You might need to have a conversation with the athlete and say, hey, if we're in an athletics department and I understand that your coach is making some negative comments about your weight and shape and that's contributing to the eating disorder, would it be possible, or would you be willing for me to go talk to that coach, provide them with some psychoeducation so that they are helping make this a safer and healthier environment for you and a much less triggering environment. So I think, you really have to do your due diligence in making sure you understand what that relationship is. But I think generally speaking, it's good to get that information out there, again, with the athlete's consent. But again, just doing a little bit of digging, doing your homework, making sure you understand what's going on there. And that relationship can be really essential to coming up with a treatment plan and an educational plan and kind of a conversation around that. So I hope that's helpful.
Thank you so much, Rachel. I just wanted to thank you all as participants for attending today's webinar. Rachel, I think everyone enjoyed it. As a reminder, you will receive an email shortly after this webinar with the evaluation, the references presented today by Ms. Flatt, along with the handouts. And in 1 week from today, you will also receive responses to all of your unanswered questions. Thank you once again for attending, and we hope to see you next month at our next webinar. Thank you so much, Ms. Flatt.
Thanks, everyone.